Good afternoon. Can you hear me okay? Anybody, you can hear me all right? Okay, thank you so much. So, what is Slough and what to do about it? And, all of you know about biofilms, right? Biofilms. But biofilms were not in the public awareness in the clinicians in wound care 25 years ago. It was a new thing. Today, everybody knows about biofilms, and we are not going to be talking about biofilms today. But you cannot see biofilms. You can see slough, but nobody knows about what is in slough. So we see it, but we don't know what is in it. That is what we are going to discuss today. So down the road, just like you think about biofilm-based wound care, you should start thinking about slough-based wound care. This is the takeaway message I want you to take from this session. My name is Debashish. I'm a scientist by training. I work in industry, and I have far clever scientists here, Dr. Kalan, to my left. I want to introduce her to you. She is an academic person, has published fantastic papers in many peer-reviewed journals, and she's in Hamilton, Ontario. And we have Christie over there, and she's an NSOC based in Ottawa in post-acute care, although she started in acute care. Is that right? Okay. So together, we are going to understand what is slough and what to do about it. Today, in fact, is the first slough-based lecture in a major wound care conference globally. And if it goes well here, we will do this many times. And so please give us feedback on how this talk goes. Okay. Okay. All right. So I have already introduced my speakers today. Our learning objectives are to understand the science behind the slough, discuss the concept of integral debridement, that's rather new, explain what is continuous debridement, and we will talk about a new dressing and a synergy between hypochlorous acid and that new dressing. And there are some real-world case studies to be presented. Now, from a company perspective, we make wound dressings, but we cannot make good dressings to address the problem unless we understand the problem. Here are the disclosures of our speakers. This is a slide about weed. Okay, now, I really thought we were going to talk about marijuana, but no. We are talking about real weed here, and I'll have Christie talk about it. She can do a much better job than I do on this concept of, okay. So, what is slough? So as commercial companies-based scientists, we are hearing a lot about we need to worry about slough, we need to talk about it, we need to understand it, what is in this yellow stuff that you see, and bang, a paper comes out in one of the best journals in wound care, in wound repair and regeneration, and its title explains it all, what is slough. But if you read this paper, it's highly, highly technical. And this requires explanation to much dumber scientists like me. And so the authors understood this, and they simplified it in this particular document, which was published by the International Wound Infection Institute. If you take a picture of this is a free download, and it is really illustrative or it's very instructive of what is in that yellow slough. So, I'm going to hand this over now to Dr. Kalan. This was supposed to be a round table, but it's anything but round over here. So there's going to be a lot of moving back and forth. Dr. Kalan.
All right, thank you. I hope everyone had an opportunity to, I'm just going to go back so that you can download this if you haven't had a chance yet. This is freely available, as with all of our documents at the IWII. So thank you so much for that introduction. This is a lot of pressure, the first slough session, so I'll do my best to walk you through some of that really technical document, showing you some of the science. And so this project really started out with a team of international collaborators, wound care clinicians, as well as scientists. And we really had this simple question of what is slough? And when I started this project, I was a very naive assistant professor just starting my lab at the University of Wisconsin. I've since moved to McMaster. And so I went around and asked all the clinicians I knew who worked in wound care, I said, well, what do you think slough is? And everyone gave me a completely different answer. So this really spoke to how important this is and how can we make new treatments and therapies and products to treat wounds if we don't even really know what the composition of some of these things are. And so our team set out to answer what I think are pretty simple questions is what does slough look like? You know, there are lots of different colors of yellow. How can we actually classify them? And what is it actually comprised of? I'm a microbiologist by training, so I'm very interested in the microbiome and in biofilms, but what about all of the other proteins and other things that are found in slough? And does it relate to biofilm? Just if you have a lot of slough, does that automatically mean you have a biofilm? And how does this ultimately impact healing outcomes and wound infection? So just to illustrate this point, we started collecting samples. Samples were collected from patients in Australia, in Denmark, and in the United States. And just looking at pictures, we do know that slough is really highly variable in its appearance, and we can attempt to give, these very descriptive words to it so we can put it into our papers like golden yellow, glossy, loose, yellow to brown. But really what, came out of this is our goal was to try to have an encyclopedia of sorts by, can we just look at the appearance and link that to some outcome or some physical characteristics? And it was really, really hard. So this is just an example of 10 wounds that we sampled slough from for this project. And I've boxed in blue, hopefully you can see that. Those are the ones that actually went on to heal within a 3-month period. So we did 12-week outcomes for all of these. And I hope what you can take away from this is you are all working in wound care. It's almost impossible, just looking at a series of pictures like this to say which one's going to heal or not with really high certainty. So what did we do? We attempted to come up with a series of assays and tests, and I'm going to really preface this by saying this was only a pilot. We just wanted to find out if we could even do this and test these assays. So we wanted to do quantitative microbiology, so we cultured everything. We did quantitative traditional microbiology by counting the number of colonies we get. We used molecular methods to quantify the stuff we couldn't culture. And then we also did what we call high throughput sequencing. We characterized the microbiome of each of these samples. The other thing we wanted to look at was the actual physical characterization of the slough. And so with this, I love microscopy because seeing is believing. So we took samples of all of these. We looked at them under the microscope. Could we see biofilm? Could we see aggregates of bacterial cells? What does the actual texture and composition of this material look like? So we used different microscopy methods for this. And then we did what's called untargeted proteomics. And this turned out to be a really, really powerful technique, because what that allowed us to do was to take a completely unbiased sampling of all of these slough and say what proteins are present in different abundances. So is it all collagen and skin proteins? Are we finding proteins coming from immune cells or from fibrin? So this was a really powerful lens, and I'll share some of those results with you now. Okay, so first, the microscopy results. What we found was perhaps not surprising is that the appearance is highly variable. And despite studies, saying 60 to 80% of non-healing or chronic wounds have biofilm in them, we really could only view what we were certain were bacterial aggregates in about 30% of the samples. So this is really, really hard to actually visualize and understand if there's a true biofilm or aggregates of cells. And so what I'm showing you here are the two on the side have bacterial cells. You can see on my left, that has a mixed culture, right? You can see some round cells and you can see some elongated cells. Those are probably from, say, like a staphylococcus and maybe a gram-negative rod like Pseudomonas. So there's mixed bacterial species in there. And then on the right is more of a typical biofilm that we're seeing. But most of the samples look like the one in the middle, just some sort of vague, indescribable architecture that we're quite certain are not bacteria. So this makes it a little bit more challenging. So just to put this, sort of at a more global picture, we were able to combine this microscopy, but then when we sampled them and did that quantitative microbiology, as well as measuring some of the proteins, what you can see is a very different picture. And so this is an example of some slough that we collected. What I'm showing you on this bar chart, just ignore sort of the genera. What you should know from these plots is that every color is a different species of bacteria, and then just their proportions. So what I want you to take away from this is that in this slough sample, there was a lot of different types of bacteria that we detected, I think over 10. And the CFUs were really high. There was over 10 to the 7 CFUs in a small sample. So that's a really high bioburden. But we couldn't see any of it. We took samples, we looked under the microscope, we tried labeling the bacteria with special dyes. We could not see it when we looked at it under the microscope. Just to drive home how challenging these things can be. What the stars just indicate what we were actually able to culture from the sample, so we could only culture about half of the things we detected. I'm very passionate about this subject. I won't talk about it now, but come chat with me later about why this might be and what it might mean. So we did this sort of characterization for every single slough sample. You'll find those case studies in the document that we just shared the QR code for you. But what about more globally? How can we look at this globally to try and actually do something and translate these findings? So what you're seeing here is just, again, I'm not sure why it's sort of grayed out, but again, we found that every single wound was polymicrobial and had a very high bioburden. So each row here is just a sample of slough, and again, all you need to know is that every color you see is a different species of bacteria that we detected from that sample. And we compared the center of the wound to the edge of the wound, and we found that there were some differences, but overall, every single sample was highly polymicrobial, and every single sample had more than 10 to the 6 CFUs. And does anyone know the cutoff for infection? This famous 10 to the 5 CFUs per gram means you have an infection. Even the wounds that healed, no problem, had this really high bioburden based on our analysis. So that's great. We kind of know this, that just looking at which species are there doesn't necessarily tell you, like, do I need to treat this as an infection or not? This is a really challenging thing. We do know we probably want to reduce that bioburden and take that stuff out of the wound. But the next thing we did was look at these proteomics. And so I'm just going to take a moment for any of the people who are very interested in the methods to talk about what we did. But essentially what you do is you take this sample, and at the time this was exciting. No one had really done this on wound samples before, or slough samples. And we digest it, so everything is digested in a tube, and it breaks it down into strings of amino acids, or polypeptides. These all go into what's called a mass spectrometer, and then it collects the data and it tells us the sequence of the proteins present. So I know my friend here really loves this slide. If you have some comments on it.
Yeah, so when I first saw this slide, as a company, I want to make a dressing that will remove the slough proteins. But there's 1,500 types of them. It really freaked me out. Like, how can we create a dressing that will remove all of them, or a majority of them? I say it cannot be done. But then hanging out with folks like Dr. Kalan and others, we found a common thread in all of those proteins. And that principle allows us to remove it. So without this research, I would not be able to, or we would not be able to really develop the products that we hope will do good things for you. So although that number is freaky high, there is a common thread, and I will explain that in a following slide. Thank you.
Yeah, so when I first saw this data, I said 1,500 proteins too. What are we supposed to do with this, and how do we actually analyze this? So it turns out I have very talented graduate students and other students that work with me that are able to come up with statistical methods to do it. So one of the things we can do is just look individually. So in this particular slough sample, we looked at just what are the top 100 proteins we detect. And what was really interesting is that we're able to see not only human, but in this particular sample, we saw lots of proteins from Pseudomonas aeruginosa and Staph aureus as the most abundant. And you can just see that, apologies, my point, I don't know if you can see my pointer here. But the green at the very top is the Pseudomonas aeruginosa, and those were the most abundant. So this suggests that in this sample, you actually have bacteria that are producing proteins, which is an indicator of like metabolic activity, and we probably want to get rid of that. Other samples, we didn't detect any bacterial proteins at all. So how can we use this to try to think about innovating on new therapeutic strategies? And so what we can do is we can just look at overall proteins, or profiles. So we can take those 1,500 proteins and we can just say, okay, well, let's just look at the patterns, the abundances of those 1,500 across all the samples. And when we do that, we found that we saw these distinct clusters. And so that's what you're seeing here. You see each subject. There's, I think, 10 here, and they clustered according to their healing status, which was really exciting because with only 10 samples, you never get enough statistical power to do this. And so we can just look at these overall patterns of which proteins are present or absent, and we see this clear clustering. I hope everyone can see like the blue and the red are clearly clustering. So the ones on the bottom are on this healing trajectory, and the cluster on the top in red are in this non-healing trajectory, or they were also selected from wounds that the patient had been, sort of ongoing for a long time. So persistence was also sort of this marker. So this was really exciting. Then we can do lots of statistics that I won't talk about, but we can say, well, what are in these clusters that are telling us if the wound is healing or not? And so when we looked at biological processes in these non-healing wounds, we see a lot of immune activation, inflammation, cell motility, right? So you can see up in the top right corner, neutrophil activation, right? Neutrophils are these inflammatory immune cells that come into the wound. On the other hand, when we look at healing wounds, we're seeing proteins involved with skin growth, turning on genes, making proteins, so skin development, right? So this totally makes sense, but we did not know this just by looking at those samples. And so my friend here is going to tell you all about liquid rotten tissue, but I really like to call this liquid gold biomarkers because we think that we can really use this to try and understand healing trajectories, and you can innovate and come up with a new therapeutic strategy and then sample that wound and say, are we shifting from that non-healing to the healing trajectory by looking at these proteins? So thank you.
So, you heard from a really academic, world-class scientist's perspective of what Slough is. You saw really advanced techniques used to needle out information. What do we do with that information? How do I translate it for my own dumb brain, and so I can talk about it in a intelligent way? So I started defining slough as rotten tissue. The word rotten is understood by everybody. Even non-scientists can understand that. And rotten tissue, according to me, can be of two types: solid rotten tissue, stuff that rotted, that you can touch and feel, flesh, skin, okay? And liquid rotten tissue. What is liquid rotten tissue? It's all that nasty stuff that was isolated and described by Dr. Kalan. These are all the stuff the neutrophils are pumping out that are harmful, that are causing collateral damage in non-healing wounds. They are all dissolved in the plasma, but guess what? The plasma precipitates when it rots and denatures, and it makes sticky proteins. It's like milk going bad. Milk is a liquid, but when it rots, the solids separate. Exactly the same thing happens in the wound. That is the yellow stuff that comes out, and there's a liquid rotten tissue. So I will be coming to this meme, or this analogy, oftentimes. Why is it so sticky? It's sticky because what Dr. Kalan has taught us through these papers is these proteins have a charge on them, and a generally positive charge. These proteins, nasty proteins, are generally positively charged. And when they're charged, they're like when you have static electricity on your clothes. It wants to stick to everything. The liquid rotten tissue, the yellow stuff, wants to stick to the wound bed, and it gives home to the germs, and it can come out with a knife. That's the best way to take it out. But you can't knife the wound every day. And so you need to find ways to remove that liquid rotten tissue. And that is where products like VASH and Ergokin AG, the images that you see, come in. So I think you take it on from here, but I'll come back to explain the chemistry of the dressings a little bit more. Christie.
There we go. So now we know and understand slough and its positive charge and makeup. So it makes sense that we would want and be looking for a product that has a negative charge dressing to help remove it. Now, I love to garden, so this weed analogy was great for me, and it's pulling out the weeds to allow the healthy plants to grow, right? That's what we do. We want the energy going to the healthy plants. It's the same thing when you're looking at healthy tissue and slough. So we're putting science into practice here. To know the makeup of the dressing is so important because you really need to know what you're dealing with, and then to know the makeup of the slough, we put the two together to heal the wound. So debridement, what, when, why? We're removing the weeds, we're allowing for growth, and we're allowing that new tissue to grow, we're reducing inflammation, and we want the best outcomes for our patients, so this is what we need to do. Now, when should we debride? That's a good question, I'm gonna get into it, but the results of repetitive debridement is basically, we want the quality of life for our patients. So we're reducing odor, excess fluid, infection risk, and amputation risk. I work in the community, and I see a lot of patients who are not able to go to work because the odor is so bad, or their legs are draining constantly, so they're stuck home. And with that comes a lot of other issues as well. So we need to get rid of the slough, heal the healthy tissue, and increase their healing rates, which essentially increases their quality of life. To debride or not to debride. So this could be a whole presentation all on its own. Us as clinicians need to use our knowledge, skill, and judgment to determine whether we're going to debride or not. We need to know our patient, what medications are they on, what is their health history, what's their blood flow to their legs if it's a lower leg wound. You also have to know your laws as well, right? If you're in acute care, there's a hospital act, you can't initiate a treatment. You need to know your organizational policies and what you're allowed to do. So I wouldn't go as far to say there's anything really black and white here. There's always exceptions to every rule, but knowing what you can and what you can't do, and it's always more important to know what you don't know and when to ask for help when it comes to debridement as well. So current debridement options, I'm actually going to go backwards, so I'm just going to get all of these on the slide. This comes across as a little negative, right? I'm going to be saying the issues that come across with all of them. It'll make sense in a minute when we put continuous debridement together. But your enzymatic debridement, it can be costly for patients. It requires frequent application, which may not always be an issue, or an option, depending on your patient's situation. Your mechanical debridement, it can be painful. You know, we're scrubbing, we're picking, these bother our patients and it may not be appropriate. Our traditional autolytic debridement can be slow, and not everyone has the time and the resources for it to take 6 months or longer for this method to work. And then our sharp conservative debridement, yes, it's the gold standard, but what happens next? Oh, but what happens next? So we use the scalpel and then what, right? This slippery slough, it's not always an option. If you've ever tried to pick up the slough with the forceps and trim it away, you can't always get a good hold of it with a scalpel. So it's the gold standard, but it's not always realistic. So this next slide here, I love this slide because this is something I do every day. I run into this all the time. We are being outperformed by our slough as clinicians going in to debride it, or liquid rotten tissue, as you like to call it. It's this vicious cycle. We go in, we remove the slough, and by the time I'm in the car without my seatbelt on, the wound has regrown this liquid rotten tissue, this slough. And we can't get a hold of that healthy tissue for a long period of time. And I may not be able to go back there for 4 to 6 weeks, okay? Now in an acute care setting, you might have, if you're not starting the treatment plan, you might have more opportunities to get in there and do the sharp debridement. But for myself in the community, I may not see this person again for months, right? So just sticking to one type of debridement doesn't work, and it doesn't benefit these patients. So my reality now, what I see in the community, is now supported by research, which is really helpful for me as a clinician. Because if I want to get products on the formulary of Ontario Health at Home, for example, I need data to back that up. And we have guidelines now that is saying that standalone debridement is not enough for a successful wound healing. So not every patient's goal aligns with your goals as a clinician as well, and that goes back to a holistic, the holistic need for you to know the holistic parts of this patient. What do they want out of their care, and what are you going to do it, and having the research to back up your care plan as well. So sharp continuous debridement of slough, we have 3 things that we need to hit here. We need it to be effective, and in my opinion, it to be effective quickly, right? It has to be accessible. So does your employer carry it? Is it on your formulary? Can you get it easily? And it must be easy and comfortable for the patient, because we need the patient to want to comply with the treatment plan. If it hurts, if it's painful, they're not going to want to do it. So I was in my clinic one day, and our account manager comes in, and I'm frustrated because I have all these patients all over the province that I need to go see and debride, and I can't get to them. And our account manager it's like she heard me. She walked in and she said, I have this new product. I said, okay, tell me more. And she said, it's called URGO Clean. And what it does is it sticks to the slough and it removes it in between your sharp debridements. And I could not have been happier. I think, okay, let's see if it works. So she gave me a bunch of the products. It also has this, this TLC matrix, and it turns to a gel, and that's what makes the removal so easy. So yes, I'm being told the data, I'm being told the information from the account manager, so let's put it into practice and see if all that's accurate and see if it works for my patients. So the mechanism of actions here, it has charged fibers. So what it's doing is it's really removing wound debris. Now, one of the biggest things I see in my population as well is animal hair. Okay, we might have a gorgeous golden retriever, and as cute as he is, he sheds an awful lot, and that wound is full of animal hair. That's one of the things I'm looking to remove, and that's one of the things I've had a challenge removing as well, is just not only wound debris, but household debris too, right? I see a lot of you nodding. The TLC matrix as well forms a gel, and that's what creates a nice pain-free removal. And I'm sure we've all had this situation too. If a dressing hurts, they don't want it, right? I'm going to pass off the, oh, there's video there. See all of that? It's pretty impressive. We don't want that on. I'm going to pass this over back to Dr. D to talk about the charged fibers.
So we're going to talk a little bit of chemistry, okay? Sorry, bringing nightmares of medical and nursing school, right? So the chemistry is simple to understand. We talked about charged fibers. Are they truly unique? You know, they are and they are not. I will tell you why I say that. Now, in the top panel, you see 3 modes of action when dressings, which are devices and not drugs, remove stuff from the wound, whether it be germs or biofilm or slough. So the first 3 modes of action are principles of physical chemistry. And we won't talk about them because they are present in every dressing. Even gauze has these to some extent. You know, when you stick gauze on a wound, it'll remove some stuff, as will every dressing, including URGO Clean AG. Those are the first 3 on top, not special. What is special about URGO Clean AG is the electrostatic interaction. This is not chemical. We are not breaking bonds. This is like many human interactions. It's purely physical, okay? So what I want to say is that negatively charged fibers are not unique to URGO Clean AG. For example, alginates and carboxymethyl cellulose are also negatively charged fibers. But the negative charges on those fibers, that's the polymeric structure of alginates on one side, carboxymethyl cellulose on the other side. The negative charges are far apart from each other. If you just count the number of atoms, they're probably 8 to 10 atoms apart. So the negative charges are far apart. In ErgoClean AG, or ErgoClean for that matter, you don't buy ErgoClean AG for the silver. The silver is there just to give it a barrier function. But in the ErgoClean fiber background, the negative charges are very close apart. They're every 3 atoms apart, 3 atoms apart. And that can actually be measured. So we went and measured the negative charge density in our labs of 3 or 4 types of dressings. We did it of the negatively charged fiber dressing. We did it for the alginates, and we also used, for measurement, carboxymethyl cellulose gelling dressing. And you can see that, sorry, let me go back, that if you compare 1.25 to 0.21, that's a factor of 6 difference in negative charge between a very commonly used gelling carboxymethyl cellulose dressing and ErgoClean. This is what makes a huge difference. And this particular very simple experiment shows that you can actually make fake slough in the lab and pick it up like a magnet with ErgoClean as compared to an alginate or a carboxymethyl cellulose dressing. So again, I want to come back to the meme I created. Now, let me ask you, I just want some interaction here. Does this concept of liquid rotten tissue make sense, or it just hokey and doesn't make sense? Who thinks it makes sense if we describe slough that way? Okay, so that's a fair show of hands. I won't ask how many people think it's a hokey idea. I don't want to see those hands, okay? So, all right. So, listen, the job is to remove rotten tissue, whether it be solid or liquid. I will tell you that VASH can soften and remove both solid and liquid tissue, liquid rotten tissue. ErgoClean AG will not remove solid rotten tissue. So if you have a scar that is bound to the wound bed with collagen fibrils, let's say from a burn wound or something like that, got to take your knife out. ErgoClean AG will not do it for you. But for the types of slough that Christie described that develops when she's acutely debrided something, she's gone to her car and it is already depositing on the wound, the dressing will remove that. So I want to bring it all this together for you in a chemistry sense, which is very basic. pH. What is pH? pH is really a measure of the hydrogen ion concentration in a liquid, right? The more acidic something is, the lower the pH. The more alkaline something is, the pH is higher. Now, what we also know is that healing wounds are associated with lower pH. Mildly acidic wounds heal better. Chronic wounds are alkaline by nature. Pathogens love that alkaline pH. So alkalinity in a wound is not a good thing. So when you go to cleanse your wound, always choose a mildly acidic cleanser. And so that is VASH. So work with me on this picture. It's a bit complicated, but I'll walk you through it. That big line, red line, stands for the wound whose pH may range from 4-ish, meaning somewhat acidic, to 9-ish, alkaline. So the 4-ish wound is nice and healing. The 9-ish wound is probably chronic and not healing too well. And there's a nice picture of slough right there. Now, what does the positive charge in the slough indicate? This is what we learned from Dr. Kalan's work, that most of the slough is mostly positive. Most of the slough is mostly positive. But you can make slough super positive. Should you make slough super positive? You should, because the dressing is super negative. So that's a dressing, it's super negative. Look at how many negative charges there are. It's all schematic, but you get the idea. Bring in VASH into the picture, that slough turns super positive. So if you have invested in a slough removal dressing, cleanse the wound with a mildly acidic hypochlorous acid-based cleanser. That is the moral of the story. So then, having explained the chemistry to you, I'm going to transfer it over to Christie for some real life cases. Thank you so much.
So cleansing versus debridement, they're not this, you have to have both. You can't do one, you can't do the other, you have to do both. When we talk about that example with the golden retriever, right? We can't just go ahead and debride and we might have 6 hairs and now we have 12, right? So we need to make sure that we're cleansing. Wound cleansing, we're minimizing the bioburden and debris, okay? But we're doing that with a cleansing solution. We're not doing that with the scalpel, which is debridement. So they're a little bit different. They sound the same, but they're different. You must do both. So when we're talking about VASH, my favorite thing about VASH is how safe it is, right? It's very safe. You get some complaints that it burns, but usually I hear that from vascular venous ulcer patients and everything burns. That's the only thing I've ever heard, but it's not the VASH, it's the wound itself. I like the dirty dish analogy. I don't think Dr. Chris Murphy's here today, but she told me this once and it made so much sense to me. When you have a really dirty pot, a pan, something, you've burnt something on it, just scrubbing is not going to remove it, not easily anyways. But if you let it sit and if you let it soak, it's going to soften all that debris and then you can remove the rest easier. And I always thought that was a great analogy, so I like to add that to all my slides. Dr. D, you want to talk about this one?
So that is actually a picture from our own lab, and I told you that VASH will actually amplify the mechanical debridement process. It's visible in the top panel. If you take slough, whether man-made or real slough from a patient, and expose it to VASH in a petri dish or a test tube, it will shrink and its nature will change. That is debridement amplification at work. So we consider ourselves to be a debridement support company with devices, not with drugs, but with devices. What is VASH doing here, just by itself, on the slough, is acidifying it, shrinking it, helping it dissolve with a little bit of mechanical help. And this is really dramatically done when you use instillation, for example, with negative pressure. But having shrunk and degraded that slough, it is rich pickings if you put ergokin AG on top of that. That is how it is supposed to work, okay? So that's the explanation of that picture. Thank you.
So this is one of my case studies. This is a very complicated patient, long-term wound, closes, gets better, needed surgery, and now is classified as a surgical wound. It presents as an inflammatory though, because if you go ahead and do any mechanical debridement, he breaks out in more wounds, it gets worse. When I irrigate it or do any type of mechanical anything with gauze, with dressings, any type of injury at all, it gets worse. So we tried a VASH soak, and this was the picture on my right. This was before we did 10 minutes, and it's so clean afterwards. I don't have a recent photo, but he is probably about half that size now, and that's what we're doing is soaking with VASH, and that's how we're cleansing the wound. Now, I have my practice that I do in the community, but in order for that to be supported by products that I need data, right? Without data, I can't support my requests for these products. This study in particular has increased debridement by 50% versus the current gold standard, which is really impressive. So using just Ergo Clean, no VASH, we've seen a huge increase in wound healing. And imagine when you add the VASH as well, you're only going to see even higher results. It seems like this is a somewhat of a new product. When it was brought to me, it was somewhat recent, just a year, maybe a year and a half ago, but it's been used globally before that. It's just made its way to this side of the Atlantic in 2023. Is that right? That's the right date?
Yeah, I do want to point out here, look, that particular increase by 50% is from a really blue chip randomized control trial of negatively charged fiber dressings versus hydrofiber. Hydrofiber also will pick up slough because it's somewhat negatively charged. But the Ergo Clean will do it a whole lot better because of the highly dense very high charge negative charge density. That's what I'm trying to say.
That's that slide with all the positives and the negatives. That
And in
you
this
just went through.
RCT, VASH was not used. So the point I'm making is by itself it works well, but you can turbocharge its effect or amplify it if we were to soften and degrade the slough with VASH and change the pH of the slough to even more positive than it normally is. Thank you.
Yeah. Having the randomized controlled trials is helpful, right? But it is in a controlled environment. So we need to take that data and we need to put it into practice. And we have the largest observational study that was ever conducted with a silver dressing. Over 2,000 patients, including 77 under the age of 18, were used in this study, and 90% of the wounds treated showed improvement. And one of the points that I love at the bottom is that no intolerance of the dressing was documented, which is fantastic. So we're talking about the biofilm efficacy. I mean, we need to know that this product works, right? And it works because we have the randomized control trial data. There's lots of data on the product. And then we take that into the observational studies and we know that it works. The combined actions of charged fibers and the TLC matrix is really what makes it a well-rounded dressing of the charged fibers removing the slough and the TLC matrix making it a pain-free removal for the patients. Did you want to add anything to that one?
No, this just shows that biofilm removal is also probably a charge-based activity that is well known and recognized, and it has been published on. So.
Yeah. So in summary here, whoops, I went too far. We know that it works, so we have to have a product that is effective. We have to have a product that is available, and for you in Ontario, it is on your Ontario Health at Home formulary, and it's pain-free for the patient, which for me, that is one of the most important things, because like I said, if it's causing trauma, if it's causing pain, they're not going to want to use it. And it also, it disrupts the trust between the clinician and the patient too. If you're hurting them, they don't like that, right? Well, Sally comes in and she uses something different and she doesn't hurt me. So I'd rather see Sally today than you. Like, you get that type of stuff all the time. So you need a product that really covers all three of those things. So this is one of my case studies. Not a lot of information on the patient, to be honest. We have a poor historian, difficult communication with the physician, but the patient does have fibromyalgia, so anything that we've done is very, very painful for them. Once we switched to URGO Clean and VASH soaks, we finally saw some improvement. This is a 20-day difference. Now, I know probably all of you want to pick away at those little crusties on the side, but we can't because the patient won't let us, right? It's a lot of pain, but the patient's tolerating VASH soaks because it's nice and easy and simple. We're not bothering them. And if I'm being completely honest, in the community, an irrigation is just not realistic anymore. I don't have the equipment to catch all of the fluid, the amount that I need. Am I seeing heads nodding? Is this kind of around the board? I don't get soaker pads sent anymore. So if I'm irrigating, I'm making a mess and I'm creating a fall risk for my patients. So I need something that I can soak with that's going to soften this tissue so it's effective, right? It's practical and it's effective. This one I want to talk about because you need to teach your patients what to expect. Again, just as we say, we're going to start this dressing on you, they're going to say, okay, that's great. And then they're going to see some of the drainage and they're going to say, oh no, it's too wet now, we can't do that. But we can do that. We maybe just increase the dressing frequency. Okay, so when you're using a different type of dressing on your patients and with your nurses, you want to educate them, provide the health teaching, tell them what they're going to expect from the dressing that you're using so that they're not shocked by this and they don't change the treatment plan.
Yeah, I got a question for you on that. The dressing will look disgusting when it comes off. and that's a good thing. It's not on the patient. I know Dr. Kalan and I have been talking about taking some of the disgusting dressings and taking it to a lab and looking at Slough. And so those of you who live near Hamilton, you know, if you are able to get some of those stinky dressings to Dr. Kalan, we would...
My address.
No.
Yeah, ship it to her, yeah. So, Yeah, it looks awful, but that's what it does. You know, you denatured the protein and you picked it up. The proteins, it doesn't look good. So,
Yeah.
just wanna make-
And, you know, explaining exactly what our treatment plans are meant to do to the patients, I find that they really appreciate that. You know, they're part of their care team. They should be told what your dressing is going to look like. Why are we using this dressing on you? Here's how it's going to work. So don't be scared to include them in the treatment plans too. And if you can't remember, I mean, we have hundreds on the formulary now. So if you can't remember, okay, I want to use URGO Clean, but can't remember exactly how it works, reach out to somebody and we're all happy to tell you. And you know, we can't absorb everything in our brains, so it's okay to not remember right off the bat, and you go ahead and look it up and then explain it to the patient. So I just wanted to add that slide because I think telling them what to expect with their wound and what the dressing is going to look like is important. So this is a young patient up in Northern Ontario, had an I-beam fall on her leg. I didn't know what an I-beam was, but I guess it's one of those big metal beams that you put in the roof of your house. So this fell off a forklift onto her leg. She needs to go back to work immediately. She's got a family, she needs to support them, we need to get her wound closed, and she can't go back to work with the leg like this. We removed the slough up here. So you see the little soft eschar, the brown part on my right? I was able to remove that with a scalpel and some forceps. And then we did Vash soaks and URGO Clean. And these pictures are only 6 days apart. So it was draining quite a bit, so we did do daily changes, and I scored the URGO Clean so that we had the drainage was able to pass through to the outer dressing. But 6 days apart is quite impressive. And at this point, I can't remember the exact measurement, but I'm about half that size now. And she's almost closed, and she's going to be able to go back to work within the next week. So I'm only at 4 weeks today of her treatment plan, and that's pretty impressive that she's going to be healed up and ready to go home. And she was one where I sat down and she said, I'm really concerned about the drainage. And I thought, no, this is something we need to address before I start the dressings. They need to know what to expect here. That's it. I'm going to pass it back to Dr. D for questions.
So, you know, I hope you like the title of the presentation. Another title I've been thinking about is, you know, everything you wanted to know about Slough but were afraid to ask. So that could be another title. But I hope this taught you about the fundamental nature of the problem and how we use the power of analysis and chemistry in the device world, not in the drug world. These are devices to address and remove slough. So we are open for questions. We have some questions coming from the web as well. So please come to the microphone, and I have Dr. Cowan here with his thing as well. So let's have some questions. Yes.
Hi, thank you very much for your presentation. 2 questions. One, you mentioned about pediatrics. What's the youngest pediatric?
Sorry, sir. Could it?
What is the youngest pediatric patient did you use the URGO Clean on? And the other question is have you had experience using URGO Clean with burns?
So let me address the pediatric question. The observational study that was described with 2,200 patients had about 70 pediatric patients. They were cut off at 2 years of age, according to the IRB approval, and there was no adverse events. I know it is used in younger patients. We just haven't published in that area. And yes, in the burn space, it is very commonly used because burn wounds, you know, excisional debridement is the first step. And but you can't excisionally debride very frequently, and then when you have liquid rotten tissue, it's better to use non-chemical methods to remove it rather than the knife. So it's used quite commonly. Thank you.
Hi.
Yes.
I have a question regarding this picture with vasculitis. I'm just wondering if we can apply this URGO Clean over this crusty area, which is painful and the patient doesn't allow to pick it. So should we cover only the wound itself, or we can include this peri wound with crust on it?
So That's a good question, and I've had it been asked before. And yes, it is creating a gel and it's creating moisture. So if you don't protect your peri wound, you would see some maceration, but protecting your peri wound should be part of all of your wound care. So that is something to keep in mind when you're using ErgoClean. But you can cut it to not overlap the wound. And if you are going to overlap the wound, that's okay too. It's safe on the skin, but you do want to protect your peri-wound skin.
Thank you. And just to confirm, we're not using this over pyoderma, right?
Sorry, what was the question?
I didn't hear that.
So we're not using this over pyoderma gangrenosum?
Yes, it's very useful for pyoderma gangrenosum.
So we can?
You can,
We
yes,
can, okay.
absolutely.
I have one here.
Yes.
I read that you're not allowed to use this tuck it into where there's undermining or into a tunnel. Is that?
That is not correct. You
Okay.
can, indeed. Christie, do you want to
It's
comment
when I looked at it on the click, connecting learners with knowledge, it says can't be used in undermining or tunnels. So I was curious when you said we could cut it, if it could be, so.
Yeah, I've used it for small undermining and tunnels before. There's a way to cut it that's like as a flower. So I don't have a one with me. I can show you later at the booth though. But if you cut it in a certain way and you can tuck it under, it depends what your goals are with that. If you want to remove that slough and there is slough in an undermining, then yes, you'd want to use it. I would be cautious with using it in a tunneling where you can't see the base because the whole purpose is to remove the slough and you need to be able to see that slough is there to remove it. So I would use it if that's what I wanted to do, but I wouldn't go packing it in a tunnel just because that's not its purpose.
Yeah, it's unusually strong without the inclusion of stitching to make it strong. It comes out in one piece, but be careful. Let me take one question from the web, and please, I will address your question.
So,
could we use ErgoClean AG in coccyx wounds that require packing, or is ErgoClean mostly for flatter wounds? I think this question was just addressed, right?
It's pretty much the same answer.
Right, yes, you can. Let me go. If there is a very small tunneling wound, 1 by 3.5 centimeter, can you put ErgoClean AG in the wound? Would you cut the product into a strip to fill the wound? Again, another question with the same thing.
It's about this, yeah, the same answer. If you can't see the wound base, then this whole purpose is to be removing slough. And if you don't know slough is down there, then I would use an alternative.
And please go ahead.
Yeah, I just thought I wanted to thank you for the great presentation. It was very informative. And I had a question about how does a negatively charged dressing affect wounds that has slough but also has healthy tissue?
Has healthy tissue.
Yeah, most wounds don't just have slough, right? They have some healthy tissues as well. And so how does your dressing, because you're putting it on the entire wound, how does it affect the healthy tissue? Does it cause any bleeding or trauma to the wound?
No, the answer is no. And that's a great question, actually. From a biochemical perspective, healthy tissue is different than slough. It's got its act together. I think Dr. Kalan can explain healthy tissue, the structure of it much better than I can from a chemistry perspective. But it's tight and it's healthy. It's healthy for a reason. It's got its act together. And so when we remove ErgoClean AG, I have never seen or I've never had described healthy tissue coming out. Can you explain that a little better than I did, Dr. Kalan?
Yeah, I guess I don't know if this one's on. I would just explain it. It's electrostatic, right? So it's not this physical, like using a scalpel to remove that. It's a very gentle way of having the slough attract to the dressing, so that shouldn't impact your healthy tissue. And as you're debriding, you're trying to remove that anyway to reveal the healthy tissue. So I wouldn't have it.
Yeah, or put another way, the dressing doesn't have enough horsepower to remove healthy tissue, but it has enough horsepower to remove liquid rotten tissue. That's one way to explain it. Yes?
I'm new to the wound world. I work in long-term care, and we have a wound consultant that comes in. And anytime I see recommend wound swab, I'm like panicking because, as you showed in that slide, there's so many bacteria. So do you recommend doing wound swabs or doing some vash and, the dressing to reduce that bacterial load?
Yeah, I think in general, the IWII also has come out with a wound cleansing document. And the rationale and the arguments for wound cleansing are overwhelming. And should you cleanse it with an antimicrobial cleanser? I think you should. That's a consensus. But the consensus also, it should be very, very non-cytotoxic. And that is where hypochlorous acid comes in. It's a potent molecule, but it has to be formulated just right. And without patented technology to stabilize it and make it safe, VASH has got a strong record of being safe. So net, yes, you should cleanse and soak with VASH. It won't sterilize the wound. It won't kill 100% of the germs, but it will make a difference. Dr. Kalan, can you address that a little bit better than I do, maybe?
So I can just repeat it. You're asking about a wound swab as well?
Yes.
Yeah.
Because it comes
For
up
the
with so
slap-
many things. Well, how do we treat that? Or should we be even swabbing so often, right?
Yeah, I mean, I think the recommendations are, and again, I'm a scientist, so you can correct me if I'm wrong, but unless you suspect like a systemic or, more deep-seated infection, you're going to have stuff come back, and that doesn't necessarily mean you need to treat it. And so we also have to think about antibiotic stewardship. For example, we see Staph aureus in 100% of the wounds we sample, and a lot of them are colonized, but they go on to heal anyway. So I would say you don't necessarily need to prescribe, antibiotics for that. So again, you just want to use clinical judgment. Is there, suspicion of a more deep-seated infection? Then you probably do want to treat that. But again, we have also found now through looking at hundreds of patients, aggressive debridement, being able to clean the wound, really helps to push it into a trajectory that's...
Yeah, I think it's a controversial topic. Should you swab or not? Because I've seen debates on the stage, pros and cons of, culturing and not culturing. Yes.
Just wondering if you have structured education or instructional programs on the use of these products for nurses working in the community.
Sorry.
So I do, where I work. When I get a new product that's coming in, is that we have a team of SWANs and NSWACs, and we do education to the nurses of how to do it. And I can even, on their first time doing it, if they're not comfortable, we would do a buddy visit, and I would physically show them how to do it, and then they would teach back, and then we move forward. So, but that's just at my organization.
But as a company, clearly, we are open to suggestions, and any training and education that we do can only be improved. So as far as, I think your question was, how can we train better in the long-term care clinical community?
What I'm thinking about is the potential of proposing or introducing new products to a group of community nurses, for example. You really have to look at what they see as barriers and problems, and one of that would be, well, how do we use it? And solving that problem by saying, here's the instructional information, here are the things that you need to know. So I was just wondering if there were existing resources now that we could point people to, either in print or video, to say these are all your considerations, these are the things you need to know.
Yeah, I think we have a certain number of webinars and talks and presentations on our websites, but I'm not an expert in that area, so I probably am not the best person to answer on the behalf of the company. Sorry. Yes.
So it kind of goes with that question. In my experience, a lot of the wounds that we have put this on, you need to fenestrate. And so my recommendation to the company would be, please pre-fenestrate your product because it needs it. Not every wound does, but most do. And sometimes it's too late. You find out after, when we have a macerated wound, that a fenestration would have been very useful. But the fenestration education, I think, is really important.
From your lips to God's ears, or to the ears of our R&D folks. And this is a running battle, I would love to have the dressing day after tomorrow, and I've been promised we'll have it 6 years from now. I'm just joking. But it's a big R&D initiative from our side. We don't want you to fenestrate. It should come free fenestrated. Thank you for making the recommendation. I hope other people in my company heard it, and we will push for it. Thank you.
So one easier way to do that, which is what I've done in the past, is to tell the nurses to cut it in strips. So fenestrating doesn't always get through, but yeah, if you cut it into small strips and place it, that allows a little bit of space, and it's more simple to explain.
Okay, I have a question from the web here. 2 questions. When you're saying wash soak, just to clarify, are you saturating gauze with wash, then applying it on the wound for 5 to 10 minutes? Thank you. Okay, so yes, there's a reason why we don't recommend spraying hypochlorous acid on the wound. It needs that soak time. How do we know this? Because we have published research in this area, preclinical and some clinical, that although you kill germs within 15 seconds with hypochlorous acid in a test tube, your wound is not a test tube, and it requires exposure, 2 to 5 minutes, and so that soaking is very important. The other important thing is don't over soak and don't under soak. If you under-soak it, the hypochlorous acid will be consumed by the gauze, and there will be nothing left in the wound. If you over-soak it, you're wasting resources. Just soak it to the extent when you pick it up, it drops a drop or 2 of gauze. And the thicker the gauze, the longer it'll stay active on the wound, or in the soaking process. In the acute care side, people don't bother changing the gauze. They change it once every shift or once a day. In the community, you want to soak it for 5 or 10 minutes. And there was another question, is it a good option for diabetic ulcers? I know the observational study we did used it on diabetic ulcers. Have you used it in practice in Canada on diabetic ulcers?
Yeah, I use it. Where I would be more hesitant is on my arterial ischemic ulcers. If I want fully dry at all times, then I recommend against a vash soak. But diabetic foot ulcers, absolutely. And you're drying the peri-wound afterwards, and peri-wound care is very important, and it often gets missed. So that's one thing, if you're doing a soak, is you make sure that the peri-wound is dry afterwards. You don't have to always dry the wound base, depending on what you're doing afterwards. But yeah, no, diabetic ulcers are fine.
I'm going to take some more questions from the web, because you guys may have the same questions. How many days can we leave the Ergo Clean? Ergo Clean is good on the label up to 7 days on the wound. But if you're removing slough, it's like a diaper change, right? Don't leave a stinky diaper on, take it out. When there is slough, it needs to come off. So change it once a day, but you can leave it on up to 7 days. The silver is good for 7 days. How long it can be used? I think we say on the box up to 28 days continuously. After that, it is at physician discretion. This is common for all silver dressings. Can I use it on a wound with scant drainage? How would you answer that?
Well, is there slough? It's really hard to answer on a specific wound because there's so many factors that come into your patient care. If I had a wound with scant drainage, I'm probably expecting it to, if there was slough, probably be more eschar because it's dry. And then I would say no, but I'd have to see it.
I think I can take just one more question and then end the session. If you put ErgoClean AG in the wound bed and need additional absorbency, would you put additional hydrofiber and super absorbent on top? Does it wick vertically? It does wick vertically. You should fenestrate it, but you would put a more absorbent dressing. You could put gauze on top, just about anything. We suggest Gratex. But
yeah,
because
I usually use a foam of some sort over top or a super absorber.
Right. I mean, this product is not really being marketed for absorbency or silver. It is meant for slough removal and the support of debridement. And then that is what this talk about. I think we have run out of time, I'm saying.
Sorry, just
One
one
more
more thing
question.
on that last one. You want to remember what you're trying to do with the wound too, right? You do want a moist environment. So if you put something on it that's too absorbent, you're counteracting what you're trying to do with the wound.
Should I end? Okay. So I think we'll be around in the booth. And do you think this information on raising awareness of slough is a good idea? What do you think? Should we repeat this talk in other parts of Canada? Okay. Thank you. Thank you for your patience. It's a new talk. I appreciate the applause. Thank you. Thank you, Dr. Kalan and Christie. And thank you, Douglas.